Hello, ladies and gentlemen. Our new program subject is head and neck cancer. Head and neck cancers are a diverse group of diseases, each with distinct epidemiologic, anatomic, and pathologic features. The natural history and treatment consideration may vary widely. In this chapter, our focus is on the primary management of squamous cell carcinoma of the head and neck. In recent years, we have observed significant advances in the diagnosis and treatment and recognition of human papilloma virus as a significant causative agent for cancer of the oropharynx. Tumor imaging is increasingly precise. Primary therapy eradicated disease in a majority of patients with early stage squamous cell carcinoma of the head and neck, and the long-term management of these patients currently involves an emphasis on general medical care, avoiding known carcinogens such as alcohol and tobacco, and participation in chemoprevention strategies to reduce the risk of second primary tumors. Therapy for patients with local advanced disease has become multimodal, and success has been achieved in improving local tumor control, disease remission, organ preservation, and overall survival. The integration of chemotherapy and novel targeting systemic treatment approaches with surgery and or radiotherapy is under study and is discussed. Epidemiology. In the United States, squamous cell carcinoma, head and neck, represented approximately 3%, 48,000 of new cancer cases, and 2%, 11,000 of cancer deaths in 2009. However, the disease is more common in many developing countries, with the worldwide annual incidence of more than 500,000. The risk of developing head and neck cancer increases with age. Most patients are above age 50. There has been a clearly demonstrated association with tobacco and alcohol use. Molecular studies provide evidence that carcinogens found in these substances have a causal role. The prevalence and spectrum of p53 mutations are greater in cancer of patients with a history of tobacco and alcohol usage than in those of without cancer of the floor of the oral cavity. Larynx and hypopharynx are uncommon in persons with no smoking history. Human papillomavirus infection is now widely accepted as another etiologic factor for squamous cell carcinoma head and neck. In the United States, more than 50% of cancers arising in the oropharynx, particularly in the palatine, tonsils, and tongue base, contain oncogenic HPV, human papillomavirus. It appears that the HPV positive oropharyngeal malignancy represents a distinct clinical and pathological subgroup of squamous cell carcinoma head and neck with poorly differentiated basaloid histopathology and marked tumor responsiveness to radiation and chemotherapy. Moreover, squamous cell carcinoma head and neck with transcriptionally active HPV-16 DNA are characterized by occasional chromosomal loss, while those lacking human papillomavirus DNA typically have gross deletion involving chromosomal arms, known to be abnormal in squamous cell carcinoma head and neck. Thus, human papillomavirus 16 infection may be an early carcinogenic effect. HPV DNA positive tumors, particularly those associated with E6 and E7 proteins, have improved survival after chemoradiotherapy when compared to HPV negative tumors. A recent case control study reported that HPV 16 positive squamous cell carcinoma head and neck were independently associated with several measures of sexual behavior and exposure to marijuana, but not with cumulative measures of tobacco smoking, alcohol use, or poor oral hygiene. These findings suggest that HPV-16 positive squamous cell carcinoma head and neck and HPV-16 negative squamous cell carcinoma head and neck have different risk factor profiles. Less squamous cell carcinoma head and neck patients with heavy tobacco and alcohol exposure are at high risk of developing multiple cancers with field cancerization throughout the upper aerodigestive tract, and bladder. Molecular evidence indicates that some multiple primary cancers within the head and neck region and the lung may derive from the common clonal progenitor cell with an early molecular alteration. The observation that treated head and neck cancer patients may have a high risk, estimated to be 3-4% per year, of metachronous tumor, has driven chemoprevention trials designed to reduce the risk of SPTs. Molecular pathogenesis. The progression of squamous cell carcinoma head and neck is thought to involve multiple stepwise alteration of molecular pathways in the squamous epithelium, alteration in the P53 tumor suppressor gene, whereas mutations in the P16 gene and inhibitor of cyclin-dependent kinase are associated with later stages of tumor progression. And continue like this. Diagnosis and staging. Different part of head and neck. I would like say something shortly. Nasopharynx. Over 95% of endemic nasopharyngeal carcinomas are classified as World Health Organization type 3 and associated with Epstein-Barr virus. Nasopharyngeal carcinomas tends to occur in younger person and is not associated with tobacco usage. Nasopharyngeal carcinomas is an aggressive neoplasm with cervical lymph node metastasis present in 60 to 90% of patients. At diagnosis, because of unique anatomic, biological, and clinical characteristics, therapy for nasopharyngeal carcinoma is distinctive. Radiotherapy is mainstay of local therapy. The anatomy of nasopharynx and tumor sensitivity radiotherapy limit the role of surgery to obtain the initial biopsy and for selected patient resection of residual lymphadenopathy after radiotherapy. And continue. Oral cavity. The majority of oral cavity neoplasm occur in the anterior 2/3 of tongue, oral tongue, and the floor of the mouth. Oral tongue lesions commonly arise on the lateral and ventral surfaces. Chirurgical resection after with postoperative radiotherapy is the most common and effective local treatment approach depending on site and tumor volume. Early cancers should be resected but may be treated with radiotherapy. Oropharynx. We favor radiotherapy using IMRT parathyroid gland sparing to mitigate long-term xerostomia as the principal treatment modality for oropharyngeal primary malignancies. Use a single modality for T1 and many T2 tumors. The most common cancer of the oropharynx are of the base of tongue and tonsil. Another subject, hypopharynx. Hypopharynx with 75 of lesion occurring in the piriform sinus. Carcinoma of the hypopharynx is relatively uncommon but virulent. At presentation, more than 75 of patients have advanced disease. Selected patients are candidate for laryngectomy. For most, consideration is given to multimodal therapy. The overall 5-year survival rate is lower than 30%. The European Organization for Research and Treatment of Cancer in phase 3 trial has demonstrated the laryngeal preservation with sequential chemoradiotherapy is feasible alternative to radical surgery for many patients with locally advanced disease. and different subject. Salivary gland cancers. Salivary gland cancers. Tumors of the salivary glands constitute approximately 500 cases per year in the United States and are distributed according to the size of the gland. For example, parotid tumors versus others. Combined modality therapy, induction chemotherapy, and so on. Radiotherapy, concomitant radiotherapy and chemotherapy. And different chemotherapeutic agent, adjuvant chemotherapy. And last subject, summary. Squamous cell carcinoma, head and neck is major international health problem. General public health strategies such as reducing tobacco usage and increasing awareness of associated risk are of primary importance. The demonstration of human papillomavirus as a causative agent for oropharyngeal cancer is of great importance, as this will carry implications for prevention and also will influence decision making in treatment planning as well as the conduct of clinical trials. The optimal care and treatment of head and neck cancer patients are multidisciplinary. Emerging data support the administration of chemotherapy as a component of combined modality treatments, especially for patients with advanced squamous cell carcinoma, head and neck. For patients with locally recurrent or metastatic disease, combination chemotherapy may produce response rates of 30 to 40%. However, responses tend to be brief, lasting 3 to 5 months, and are associated with only a modest prolongation of survival. Thus, chemotherapy for these patients is palliative. An exception to this is for patients with MPC with higher response rates and a small proportion of long-term disease-free survivors. For patients with metastatic squamous cell carcinoma, head and neck, or any primary site, the addition of cetuximab or platinum fluorouracil appears to improve tumor response and overall survival. More targeting agents are currently under investigation. Prognostic factors are needed to improve selection of those patients who are most likely to benefit from palliative treatment. In the newly diagnosed patients with locally advanced disease, high response rates have been observed with induction chemotherapy. The addition of the taxane to the more traditional cisplatin fluorouracil platform has increased efficiency without a notable change in significant toxicity. The major objective of induction systemic therapy is to reduce the risk of distant tumor recurrence, the potential for augmentation of local control with a substantial response to chemotherapy followed by definitive surgery or radiation is also under investigation. 3 large multi-center randomized trials have been successfully conducted with preservation of laryngeal function in subset of patients. Chemotherapy administered concomitantly with radiotherapy has improved local control and survival in a sequence of studies. The increase in toxicity associated with these regimens should be carefully considered in selecting patients for combined treatment. Patients with earlier stage disease, stage 1 or 2, generally should receive therapy with either surgery or radiotherapy or both. Patients with locally advanced M0 disease may be considered for non-chirurgical therapy, most often with chemotherapy and radiation, or entered into combined chemo-radiation treatment protocol. Patients with resectable disease can be further divided by CT. Patients with primary oral cavity tumors are best served with surgery followed by radiotherapy, chemoradiotherapy if there are high-risk pathologic features, whereas those with oropharyngeal, hypopharyngeal, or laryngeal tumors are often treated with radiation with or without chemotherapy, depending on precise site and stage. Patients with metastatic disease should receive systemic therapy with palliative intent if performance status is favorable. Enrolling in the investigational studies is strongly supported. Basic and translational chemoprevention research in head and neck carcinogenesis is advancing our understanding of the molecular characteristic of carcinogenesis and cancer risk. We are studying epidermal growth factor receptor inhibition in the prospective control trial in high-risk patients. This project illustrates the convergence of prevention and therapy as promising new approaches with molecular targeted agents such as cyclooxygenase 2 and epidermal growth factor receptor inhibitors test principles known to also have efficiency in the setting of invasive cancer. The management of head and neck cancer is a multidisciplinary activity. The identification of effective chemotherapeutic agents and their integration into the initial therapy of head and neck cancer have the potential to improve survival time and preserve organ function. Through well-designed and executed clinical trials, coupled with basic research of the biology of the upper aerodigestive tract tumors, further advances in the management and prevention of these cancers can be achieved. That's all. I would like to finish at this point, and next program subject more so much amount information and gastrointestinal carcinomas and different subjects, so many. Next program. Thank you very much. You are patient. I hope this public health educational cancer disease would become useful all over the world people. Thank you so much. Thank you very much. See you later.